Yeah, when I've met you, you've been walking on your treadmill before, a little bit like one of our fellow chairs in the Acute Trust. But you're very welcome. So we got an update now on freedom to speak up. I don't know, Natasha, you're going to go straight in, or if Elaine's introducing. Either way, over to you, please. Thank you.
Thank you. Thanks for having me, guys. Lovely to be here for the first time. Obviously, I've submitted my action plan for assurance today. I will run through sort of a bit of a brief summary, if that's okay, and then move on to my ask to you guys on the board, and of course any questions you might have to inform that as well. So just as a brief overview, I came into post as our first substantive post guardian on the 1st of June. Between myself, Elaine and Tessa, we agreed in sort of my first few weeks that probably what would be useful would be to complete an action plan for Workforce Committee and to bring it to board once that had been approved, focusing on some really key areas in terms of our journey as a trust in terms of freedom to speak up. So the focus areas for my action plan, which takes us up to March next year, are around our governance, how we manage data, and also stakeholder engagement. This action plan did go to Workforce Committee earlier this month and was approved as far as I'm aware. My hope is that we can approve the action plan today with a view to providing a full report either later this year or early next year in terms of an update on the action plan and a sort of more detailed overview of where we are in the organisation and the progression we're making. Just as a side note that's not mentioned in my action plan, but referencing to the Lucy Letby case, the reason it's not mentioned specifically within my action plan is because it was written before we had the outcome of the trial. But with regards to the specific points noted in the letter sent to boards with regards to the case and their speaking up arrangements, I do feel quite confident that the action plan addresses all of those, although it's not referenced explicitly. So my other asks to you today, as well as sort of approving the plan and hoping that you're feeling assured having seen the plan that we are progressing, is to advise when you'd want another full report, an action plan update, and what the content would be. And I'm happy to take any other questions, and I can see Tessa's got her hand up already.
Okay, Tessa, you're all dark. We're not seeing you, but hopefully you're there. Over to you.
I can promise you I am here. I just wanted to pick up on what Natasha said, that the action plan was approved at Workforce Committee, and we did also receive the Lucy Letby letter as a matter of any other business. And I think the point I would like to make would be the same as I made at Workforce Committee. Whilst freedom to speak up has a significant role to play in the trust response, it is not the only piece in the jigsaw puzzle, and we can't expect freedom to speak up to do it all. It's really important that as we go out to staff, they understand all of the routes for speaking up, and that we don't all just look to Natasha and say, over to you. So I just wanted to make that point, that it is really everybody's business to be approachable and be able to play their part in the speaking up agenda.
Thanks, Tessa. If we go to Janet and Sarah after that. Janet.
Yeah, thank you. Yes, I wanted to repeat what I said at the Workforce Committee, actually here at board, to say how pleased I was to see this action plan. I thought it covered all the right areas. I thought it had the right amount of detail in it. I was really pleased that it got timescales that actually looked realistic and achievable. So I did feel this gave quite a good degree of assurance that actually Natasha's mapped the issues and is looking at appropriate ways of addressing those, which I think is really important. She asked what we would like in future, and I think what I'd like is updates in a similar format, so that we can actually see how she's getting on. I think the other thing that I would be really interested in is any challenges or blocks that she's finding to progress. And actually, having heard her speak twice on this and seen the report, I feel confident that she'd actually be able to give us some answers as to how she could get around those challenges or blocks. But I think it's really important as a board that we're cited on what's happening, but also, how we can help to support her. So I suppose that's my question back, actually, Natasha, is, as a board, are we supporting you in the way that you would want? And is there anything else that we could do for you?
Thank you, Janet. I do feel incredibly well supported so far, in all honesty, both internally and externally. I do get a lot of support externally in terms of Guardian mentorship and support networks, but internally everybody's been really sort of engaged with me since I've come into post. People ask a lot of questions. People are very open to my ideas, to my feedback. So that's been really good in terms of forming this action plan. I guess what I would say is this action plan is evolving all the time. We kept it quite focused because we know there is a lot of work to do, and we wanted to make it exactly as you said, Janet, an action plan that is measurable. It's got timed outcomes. We will be able to see progress with this, but also there's a lot sort of feeding into it that's going on as well. For example, we've had Lucy let the outcome in the meantime, and I did make sure that was referenced in the action plan, that actually things can change, particularly in terms of our CQC report and that kind of thing. And on that note, one of the other things that's sort of developing now, but will form part of the governance aspect of this action plan, is looking at things like our reflection and planning tool from the National Guardian's Office and developing that as a board and throughout the organisation. So really, in terms of support from you guys, for example, that's one thing that I will need your support with, for example, as time goes on, in terms of us all engaging with that and looking at, exactly as Tessa said, what is our response and action as an organisation, with me supporting as the Guardian, but actually what are we all doing about our culture in terms of speaking up?
Thanks, Natasha. Sarah.
Thanks. Fully support the action plan. My question was more about the drop-ins you're doing, which is really helpful, Natasha, and what sort of feedback you're getting from staff, because there's often speculation of whether people know how to report or don't, whether they don't for a variety of reasons, and often a lot of assumptions made around that. So I was just interested, what's the emerging feedback, and does it give us any insight, particularly around things like whether the champion role would work or not, or whether we need to adopt a different approach? I'm just interested what the headlines were.
So it's interesting, actually. So just to let you guys know, in terms of drop-ins, so I started offering drop-ins pretty much straight away as soon as I came into post, and have now made a more robust plan alongside Kate Leith for the rest of the year in terms of offering drop-ins around the county, which has its challenges, as for people like myself and Kate and other people who are a singular person in a singular role for the entire county. Making yourself visible is incredibly challenging on the ground, because realistically, you can try and get out to as many places as possible, but we have so many bases that is a challenge. So how we're looking to address that in the interim is we've made this plan till the end of the year, and then I will make another plan after the Christmas period, looking at other bases I haven't been to. Just with regards to drop-ins, it's interesting because, and I have had similar feedback from Regional Network. What I tend to find with drop-ins is you don't get many people attend to raise concerns. You do get people raising concerns, and that's in my report in terms of figures. You do get people attend to raise concerns, but on the whole, what I find with drop-ins is they're much more effective in terms of getting out to people and raising the profile, sharing the message. This is how you can raise concerns. This is who I am. This is my role. This is what we want to achieve. And what I tend to find is people will go away and digest that, and then they will contact me afterwards. So I get a lot of people who will then call me in the following days and weeks to say, oh, I noticed you came to us at drop-in, or I saw details of drop-in, but I couldn't get away to see you, but I did want to speak to you. I think there is a big issue no matter how you run a drop-in terms of people do have that fear of someone will see me, they'll want to know why I was there, even if they're just coming to ask me about speaking up culture and that kind of thing. There is that sort of stigma, I suppose, for some of our staff, and so I don't find them to be I do find them to be a good use of time, but more from an awareness raising perspective is what I would say. And And just touching on it in terms of sort of themes and sort of feelings that come from those drop-ins or from those conversations. I think at the minute, if you look at the figures in my report, it probably looks like we've got a bit of a peak maybe, and that maybe our figures are a little bit out in terms of compared to the national picture, although not greatly so. And some of that might be around the fact that, we're doing increased promotion and I've got more availability because of the hours I now work in terms of getting those messages out there and helping people to understand how they can speak up in the organisation. Heavy focus on issues around staff wellbeing. So probably where we differ a little slightly differently at the moment to the national picture is in the national picture, in the latest Guardian report, Guardian Office report, there was kind of an even split between staff wellbeing, patient safety and bullying and harassment. I find that we have slightly less of a figure around patient safety, as people come into me as that's their concern. But often what I find is I can pull patient safety out of that because it tends to thread through, and conversely so does staff wellbeing as well. So I tend to find there's quite a lot of themes that run through each case rather than just one theme, if that makes sense.
Jill.
Yes, it was just in terms of Natasha raising the issue about reporting back. Obviously, it's a standing item on the board agenda every 6 months, and Natasha has an invite if she ever feels the need to come to board, to come to any board meeting, and has open access to Mark and Sarah. But we do need to complete a return at the end of January. And so I'm just wondering as to whether we actually change the reporting just for the next time to come back in January, because obviously then Natasha could update on the work that's been completed and ahead of the return that's going to be made. And then we take it forward 6 months from there afterwards.
Thank you, Jill. On that very point, I think we need to start at the subcommittee level before we determine how often Natasha comes back to board. Tessa, could you remind us how often do you receive an update report? I don't mean on the action plan, but in business as normal, a report from our Guardian on number of cases, any links between cases, all those sort of things. How often would you receive that?
I think we're the same, that it's 6 monthly formally and in between as and when necessary if there was an issue. But I was going to make the suggestion that we received the update in the January Workforce Committee, and then it can come to board in January, and then we can get into the right reporting cycle, because I think we did have the plan in November, but it would be really good to see the progress being made, particularly early next year, if we think that we'll be progressing the CQC Act plan on that sort of timeline and trajectory. I think they'll weave together well. So I would recommend that we have a formal report for the January Workforce Committee. Obviously, Natasha talks to myself and Elaine in between. And we can always escalate it to bring something to November if necessary, but I suspect that would be too soon anyway.
Thank you, Tessa. I'll come to Elaine in a moment if it's on the same theme. I feel a little bit uncomfortable with 6-month gaps. I know we're not suggesting that initially, but because it's high up on our agenda, isn't it? It's high up as part of our improvements. 6 months feels too long to me with regard to reporting to workforce, at least, maybe even board. But I want to start with workforce before we elevate to board, because obviously workforce can elevate anything at any time. So I have no desire to bounce you at all, Tessa, into anything. It's your decision, and maybe we should discuss outside. But I'd like to think standard reports come to Workforce Committee more often than 6 monthly.
Mark, if I could suggest perhaps we have a verbal update in November, a formal paper in January, and then we can look at the frequency going forward from there.
Yep, I'm absolutely fine with that. I just want us to be on top of it, so to speak, so and I know it'd be emerging. Maybe eventually we get to a 6 monthly or whatever it is, but I think in the short term we need to keep a tight eye on this one. So yes, thank you, Tessa. Natalie, then Elaine.
Thanks, Mark. I guess just a couple of reflections again. Yes, Natasha, really helpful report. Thank you, with good timelines. I just wanted to, I guess, bring people's attention to the primary reason for contacting Freedom to Speak Up Guardian. Continues to be mostly around bullying and harassment. Now, we know that the Guardian role's changed from its infancy, but I'm still slightly concerned about the lack of patient safety concerns that are being raised up through the Guardian. So Natasha and I have spoken about, are people using other routes? How are we monitoring those as well? So just to reflect that we are having those conversations, and I'm really keen to see how we make sure that it is being used for that purpose as well. That's a really paramount kind of importance for me. And then secondly, it's around the feedback. I think just to note, it's not just about listening, isn't it? It's about making sure that staff understand we've acted. And often the confusion with that when we can't tell them what we may have done from them raising a concern. And that's one of the subtleties, again, I know Natasha's working through, that's going to be really important, so that staff know we have listened and acted as opposed to just listened.
Thank you, Natalie. Elaine, your hand's gone down. You sorted your point made?
Yeah, I think Tessa raised it, but I was conscious that we haven't formally discussed it about the frequency of reporting. So I think we'll pick that up anyway. And also to Natalie's point, as Natalie was saying, we've started to meet formally with Tory and around patient safety, and if those concerns are coming up, to ensure that there is a tighter triangulation between Tory's work, what's going on in the Freedom to Speak Up space, HR, EDI. Those are the four of us that meet on a monthly basis. So I think we hopefully should be picking that up in a more explicit way and integrating that into the report. But my question was essentially around frequency of coming back.
Okay, thank you, Elaine. One specific thing for me, but first, I should have welcomed you, Natasha, as your first meeting. It feels like you've been around longer than that, which I think is a success. Is your activity and your promotion of your new role is such that I hadn't switched on to the fact this is your first board meeting. So my apologies for the discourtesy. You're very, very welcome to your first meeting and subsequent ones. My question, and it may not be for you, maybe elsewhere, is I did notice that casework and the resources allocated to casework seem to take an awful lot of your time. And I think this is another indicator of the success of your, for want of a better term, marketing the role and marketing what you can do. But I did note the length of time in your report that it says to get cases sorted out and how quickly you can do it. Are there enough resources there, and what can we do about it? Which is probably a question towards Elaine, maybe Sarah, more so than yourself, because I understand you're probably doing as much as you can. So what can we do, folks? The resources seem a bit limited for the casework. Any views, Sarah?
I understand from Natasha that the champions can't pick up any casework, which does mean that a much higher load of that type of work falls on Natasha. My gut feeling is you're also getting a bit of a backlog, though, Natasha, because you've come into post, you've got more hours, probably more people are gravitating towards you with all the awareness raising. So I do want to see if it settles down or not. I think one of the issues with the casework is that usually it's cases that have gone elsewhere and therefore are often quite complex because they're coming to Natasha because they've tried lots of other routes, but that does mean it is more complex for Natasha to sort. So I don't have an immediate answer, Mark, but I would like to monitor it for slightly longer, because it's just whether it settles down or not. Might grow further than Natasha, hadn't it? In which case we'll have to do something different. But it's interesting that the champions can't pick up any casework, so that does affect how we deal with it moving forward.
Can I just mention about champions as well? Sorry to cut in, because you did ask that, Sarah, and I didn't respond to that part, because it is mentioned in briefly in the action plan, but not in much detail. The reason for that is because we know we need to grow our champion network. It is a priority for me. However, my feeling, having come into post, is perhaps there is more work around stakeholder engagement that needs to be done first, in terms of getting people on board with what actually is the champion role and understanding that, and what do we expect of them, what can they do. So you're absolutely right, Sarah. For example, they can't manage cases. The champion role from the Guardian's office perspective is much more about that demonstration of culture and being that ambassador for a freedom to speak up culture. And they can signpost to the Guardian, and they may think actually they could signpost elsewhere in the immediate terms if somebody did want to discuss a concern with them. But yes, absolutely, in terms of caseload management, that is very much for the Guardian to do. I would agree with what you've said, Sarah, as well. We're in a bit of a difficult position at the minute. What we can't see yet is, will it settle down, or actually will cases increase, because we know that we're on a longer journey and that there is promotion work to be done still. Some of the issues around cases taking a long time to resolve, absolutely. A lot of them that are coming in are quite long-standing, complex cases. And also it's about people's capacity in the organisation to deal with concerns as well. It's not always easy to get a quick resolution when everybody is struggling with capacity. And just to touch on the aspect of what we share with people when we do act, that is an issue, and something I have raised in terms of, yes, we know we have a duty to maintain confidentiality, but what work can we do in terms of particularly that sort of immediate line manager support to help staff to feel assured that whilst we can't share everything we're doing, we are acting on what you're saying.
Thank you, Natasha, and thank you for your report. There are 4 asks you have on your report. If I take number 3 and 4 first, which is around reporting back to board and content, that will emerge from the discussions between no doubt yourself, Elaine, and Tessa, with that caveat that we as a board and indeed subcommittee need to be sort of all over this in a way which I know will be helpful for you. Number 1 is to be assured on current freedom to speak up activity in the organisation, and that is obviously linked to approving the action plan. Board, can we approve the action plan as presented by Natasha? Yes, you can take that. No great surprise, but yes, and certainly I take assurance and reassurance of your activities. And the report that you brought forward I found particularly useful, Natasha. I know I speak on behalf of board in its entirety. Your role has our full support, and you personally in that role. You absolutely have our unequivocal total support in what you're doing. And I think you found quite early on that if you need anything from any of us, from myself or anybody else on the screen, then you merely have to ask. And I know everybody's willing to help in any way they can. So thank you for what you've done since you start. We all wish you well and keep going. You're doing a great job. Thank you ever so much indeed. And we can note the contents of that report.
Take care. Thanks for your time. Bye.
Thank you, Natasha. Bye-bye now. And thank you to those behind the scenes, Elaine, team. We don't know who it is very often, giving that support and making these things happen. I know, Sarah, you've had an influence, and others as well. So it's a key aspect of what we're doing. It's a key aspect of our CQC improvement plan, and it's really energizes how I feel that area is. So it's great. Okay, we go now on to our standard reporting, and we get to the first one, which is Quality and Safety Committee. Janet.
Thank you, Mark. Okay, so you've got the report here from the committee about items considered in the assessment of assurance. I don't intend to go through all of it because it's quite long. We also have the quality and safety report attached to this, which actually covers a few things. We've got coverage in both, really. What I do want to pick out were the 2 emerging quality concerns that we discussed, one of which was sexual safety in mental health, which had been highlighted at an earlier meeting, and we had a report back giving us more information about that and looking at the actions that were being taken. We noted that satisfactory progress was being made against the action plan, and so in future we'll have reporting through the normal governance reporting channels. We also, another emerging risk was around risk assessment in mental health, because there is now guidance that actually we should be moving away from tools that actually assign risk as high, medium or low. And in fact, the GRIST tool, which is currently used, does that. So straight away, actually, clinicians are going to be actually adding narrative to explain why they've given that rating. But then there is work to actually look at how we can replace that going forward. So the committee was aware of that. Other items I wanted to pick out around the clinical strategy implementation programme. We had a report on how that was going. And I think we were concerned to hear that there are some areas where people actually feel that they need permission to act. And we had quite a long discussion about actually how we need to look at the culture associated with that, and empower people so that if they do identify areas where they can improve, that actually they feel able to undertake those improvements without waiting for a bureaucratic process. Other things I wanted to pick out, we had quite a lot of reports for assurance. A lot of those are actually in the quality report, which is appended to this. The couple that I actually wanted to pick out and note were particularly around the complaints and PALs and the friends and family tests, which where in the past, because for example, friends and family tests has come out with quite high percentages of positive feedback. I think maybe we haven't given it the scrutiny we needed to, but just looking at the numbers associated with that, which actually the numbers are quite small, and we need to look at how we can actually improve and increase the amount of feedback we're getting. So we scored a number of areas there as level 1 assurance, which is the lowest. But I think as a committee, we were assured that actually the problem has been identified, and now actually the work is taking place to actually look at scoping the issues and putting together an action plan to address those. And as I say, most of those are actually within the quality report, which is appended. Just a couple I wanted to pick out. In addition to that, was the complaints recovery plan, which was an internal audit, looking at actually how we can actually address the issues we've got around reopened complaints, and also responding to complaints within timescales. And we've got an action plan associated with that, but at the moment we felt our assurance level was only 2. And then the other one I wanted to pick out was the medicines management update report, which actually identified quite a number of issues, some of them around resources that actually needed addressing. So I think the assurance level that came to the committee was level 3, but we actually downgraded that to a level 2, although there are action plans associated with that. I don't think I wanted to pick anything else out in particular. Oh, just finally, the quality improvement annual report. Actually looking at this, there is an NHS impact self-assessment, which we're going to have to do, looking at our approach to quality improvement against that national tool. And hopefully that's going to actually help us to look at addressing how we take that forward. So Natalie and John, I don't know if you wanted to go through the summary report associated with that, or whether you were going to take that as read.
Shall we just pick up the question or query from Jill first?
Yes,
before
sorry,
we then
yes,
go on? Might be an easy way to do it. Jill.
Yes, it was something that I've picked up with Natalie. Unfortunately, I wasn't at the meeting, or fortunately, because I was on holiday. But on page 116 of Diligent, it references Mental Health Act unannounced visits, and this was the report and action plan, I think, from a Mental Health Act visit. These are taken through the Mental Health Act steering group. There's an executive sign-off process, then it goes through the Mental Health Act steering group, and then that reports onto the Mental Health Legislation Committee. And so where it refers to a lack of evidence of reporting through governance structures, I think we've got a bit of an overlap between the work that happens and the assurance that's provided in Mental Health Legislation Committee and what had obviously come here to Quality and Safety Committee. And so Natalie and I just need to work through how we're going to make sure that we're not duplicating work, and that we're focused on what each respective committee is doing and what the focus is at Quality and Safety, as opposed to the focus at Mental Health Legislation Committee. So we'll obviously do a little bit of work to make sure that we're absolutely clear about that, so that we don't have duplication.
Thank you, Jill. I guess Tessa, you're going to comment on the Mental Health Ledge as chair.
Yeah, I was going to say, I think some of this is due to the fact that the committees don't align. Mental Health Legislation Committee only meets quarterly, not bi-monthly. So I think there's an issue about the timing, and sometimes reports are going to one. But I agree with Jill. We need to drive out any duplication of effort, because all of the committees are busy enough. They don't need to be doing business twice. So I welcome the review of what goes where.
Okay, thank you. Janet, were you handing over to Natalie / John at that point?
I was, if they wanted to add anything to the report, yeah.
Yeah, that would be good. Thanks, Janet. Thanks, Mark. I guess just to complete that conversation as well, that I think the important thing for me when we were having that discussion is around how we're pulling the learning from that mental health act visit and making sure those themes around patient safety and quality are being embedded in the work of Q&S and making sure that teams are embedding it. And that's the bit of the loop to close, isn't it? So that's where that discussion came from. But thanks. I mean, Janet's gone through it. I just wanted to bring a couple of things to people's attention. Just to note, we are continuing our movement towards the patient safety incident response framework. So this is the new PSERF. So we're testing out a new way of approaching falls. So this is moving from the very traditional SI RCA route to a new way of looking at serious incidents. So we're testing out a couple of different approaches relating to falls, and the reporting system that will enable us to move into PSERF is now implemented. We're testing it out and we should be ready to go live in October. And we're working closely with the ICB around the learning as well as a system to implement PSERF. We're also going to try bringing together a couple of groups called the Mortality Oversight Group, which will bring together learning from deaths, end of life, resus and suicide prevention to, again, it's something one of our system partners is trialling to see if that can bring those agendas closer together and enrich that learning from all of those as well. And finally, just wanted to bring people's attention to the sequins that are outlined in the report. Q1 gives us our baseline measurement, so we know if we've got any tricky issues around any of our sequins. And you'll see that one has been flagged as a risk of us not achieving, which is the outcome measures in mental health. So we do have a robust plan in place, but there is a risk that we might not achieve that sequin this year, but we're working hard to ensure we get as close to it as possible. Thank you.
Thank you, Natalie. I assume, John, you got nothing to add to that? Okay, thank you very much.
No, thank you, Mark.
Any questions at all on any of that? And we're being suggested assurance levels for the variety of matters touched upon. Does anybody have any comments on any of those, or can we accept those? Okay, obviously the ones down in the red there are the ones that cause you, the eyes are drawn to the red, aren't they? But I'm sure the committee and our teams are focusing on those. So if we can note that report, please. Thank you very much. And move on to the easy subject of workforce. Tessa.
Thank you, Mark. I think actually a lot of the issues that are being reported from Workforce Committee have been picked up already on the agenda today, which is good to know. I think it's just important to note that the Staff Mental Health Wellbeing Hub closed at the end of August. Things were being moved forward to look at how we covered that gap, but I think that's something we need to keep an eye on. I think there's still focused input into Crest state facilities, and we also did a sort of stock take on are things okay in Mortimer, because that was one of our emerging risks a while back, and we wanted to check that things were stable, even if not improving there, and we were assured that that was the case. Things hadn't got any worse. Attraction and retention remains a challenge. We had a very positive report on apprenticeships, and we're also aware that we need to do some more data analysis of the information around leavers and why people are leaving. On a positive note, the safe staffing level had moved to a level 4. That was partly due to the fact that establishments and budgets had been aligned, and the level of appropriate staffing was being recruited to. Not to withstand the fact that there's a challenge with recruiting, but at least we now know what we're trying to get to. We had a detailed discussion about the use of agency, whether it was on framework or off framework, and there were some reports of positive progress and some areas that were doing really well, while other areas are still challenged. And we noted the sickness levels in community hospitals with some improvement, but still needing to be watched very carefully. I think that's probably everything I wanted to pull out. Apart from the patient experience dashboard, we gave that a level of 3. Work is progressing. One of the challenges with this, as with the recovery plans, and we had 5 recovery plans at committee in September, and we'll have 6 recovery plans by the committee in November, is the time lag and the challenge of some of the data is being pulled from staff surveys and pulse surveys that only happen every few months, and therefore progress is really difficult to monitor. And we've asked Andrew and Sammy to look at whether there are any proxy indicators or other data that we could be using to help us monitor progress, because these are quite challenging areas. And as I say, we've got a new recovery plan due to come to committee in November, and that's around senior leadership and BME. Happy to take questions, Chair.
Any questions for Tessa before I move on to Elaine? Jamie?
Well, I was going to ask this question of Elaine because it's in her report on the staff health and wellbeing hub, but since Tessa referred to it, I'll ask it now if I may, and it's really just to query, because I'm not very familiar with this. Is there an evaluation of this? Did it work? How effective did we think it was? And really, how significant is its closure for our wellbeing offer to employees, or is the support going to be offered and made available in other ways?
I'll try and answer your question in a logical sequence. The offer to continue health and wellbeing, that's gone. What they sought to replace it with was a regional offer across the whole piece. I think we were offered something like 200,000 between kind of 11 bodies. The intention is we try and do something in a collegiate way with the Black Country. But the work that we're going to do for our ICB will be through some curated content to support staff. That's our normal offer will continue, NOS, etc. That still continues. In terms of evaluation, that's been done within our own ICS. Use of staff by staff has been good, but primarily from NHS rather than outside of the NHS. There is still some apprehension about using the service. However, given all of the challenges that we have as a sector, it feels a little short-sighted that we weren't able to continue funding it, since health and wellbeing probably sits at the heart of some of our retention challenges, but we're looking to continue to deliver something. So a lot of work was done at an ICS and within trust by Kate Lees. I think that's where we are at the moment. Jamie, we've continued to offer something, but not as comprehensively as we have previously. The national feeling has been that there wasn't sufficient data to say that it was, for want of a better term, worth keeping. And I think there was a lot of lobbying nationally around this.
Thank you, Elaine. I did express my disappointment of the losing of something in multiple forums, actually, the losing of something which is set up to assist staff at this very difficult time when staff are, considering their employment in the NHS or considering it, all those continuing it. But we are where we are, and hopefully we can put things in place locally ourselves or alternatives to make sure our staff are supported. Because apart from anything else, the message I thought was terrible to our staff. We're going to stop funding staff wellbeing, which of course isn't the case because we've always had wellbeing provisions in place anyway. But I think the message was poor. But it's outside of our level, so to speak.
Can I continue into the integrated
Matthew
workforce. Oh, sorry.
I was going to wait a second because Matthew had indicated he wished to speak. So, and then we'll come over to you, Elaine.
Okay,
Matthew.
Sorry, it may be a detail that Elaine was going to pick up anyway. Just I guess some positive messaging around retention in both mental health SDUs and also in children, young people and families. We've had a month-on-month improvement in the rolling 12-month turnover rate over the past year. And in fact, all 3 SDUs are now well within the Trust 12.5% turnover target. So that's actually an improvement in all 3, an increase in workforce in all 3, and a decrease in turnover in all 3.
Thanks, Matthew. That type of news is always welcome if it hasn't been picked out adequately in the reports. Thank you. Elaine, over to you for the workforce.
My only comment was to probably reiterate, so I don't want to duplicate what Tessa has said because she pretty much said what I was going to talk about. What I would note is we are in a process of real transition as an organisation, and I expect to see perhaps some more pronounced emphasis on things like health and well-being, retention, the importance of having stay conversations with our staff and addressing issues that might impact on staff coming to our organisation and staying in our organisation. And that sits alongside this real cultural piece that we've already embarked on and engaging our staff around it. So I just wanted to put that on the table essentially, because I think what we'll see is more of a pronounced emphasis on things like employee relations, on freedom to speak up, on staff leaving or staying, and how we respond to that. And at the heart of that is the need for us to really focus on being an inclusive organisation, that we're open to learning and we're prepared to challenge ourselves and listen to the voice of our patients and our staff. And that sort of sits in a lot of the conversation that we've had this morning. Some of the things that we're encouraging our managers to do is to have meaningful appraisal conversations with their staff, to assess issues of health and well-being in a timely fashion, and to create that culture where staff can raise their concerns without feeling that they're going to have a detriment. So we're supporting those vulnerable areas that we know of and they've already been mentioned. Sensitivities, we're going to be doing a little bit more of that as time unfolds, but it sits in that wonderful area called workforce.
Thank you, Elaine. A couple of very quick points I make is with regard to dashboards. I know Sarah's kindly bringing along some expertise in the next non-executive director meeting next week. Power BI, Business BI, I always get confused, whichever one it is. So non-executive directors will get a better understanding of that system, and what that also does is give us the ability to perhaps know what we can ask for a little bit better on dashboards for us, which would be useful. The other thing for information members, and I'm sure other colleagues are aware, that was a regional meeting this week with regard to a variety of things, and it was pointed out that mental health trusts, that's a big generic statement across the whole country, they were the ones driving the difference between off-agency and agency spend, and it generally felt that acute trusts had reined in the off-agency and mental health trusts hadn't reined in the off-agency. And I know Robert's just about to come on to where we are on our finances and that, but I'll just point that out before we then come on, and I'm sure Robert will make a comment about our agency spend as part of his report. So with that, we could know the workforce agenda, and thank you, Tessa and Elaine again. And there's a huge amount going on, a huge amount of frustration on engagement as well, because it's such a difficult area to try and deal with. But thank you very much. We can note all that. We can then move to Robert Birage is with us because obviously he's down in London, but I know there's a couple of other non-executives on the screen that can contribute to the reports on that area. Robert.
Thanks. Yeah, if I step through the 2 reports as normal, and then I guess in questions, if there's any particular comments around the committee report, colleagues, and I can pick those up. So if we just pick up the performance reports, first of all, A few key points to draw out. First of all, obviously, from a system perspective, a lot of attention is focused on urgent care, delivery of the elective weights and the like. And as has been touched on earlier, the ongoing industrial action is clearly having a significant impact on that. And as I'll pick up later, that clearly also feeds through into the overall system position around finance. That's quite an important contextual piece to understand. Continuing with the headline messages then as well, we remain as oversight framework segment 2, and actually it's this week coming. So this Friday we have the process that we're now going through with our ICB colleagues, who are running that in partnership with the Midlands team from NHS. So a few of us are meeting on Friday to run through that. I think we are expecting that for the moment we'll be remaining in segment 2, and as previously explained, that's more contingent on the outcome of the overall CQC visit, as well as some of the metrics that we have, and clearly we're still waiting the publication of the report from that perspective. So from a kind of an overall segmentation perspective, we remain as we were. Just drawing out the key elements then, stepping through the 5 domains that we have, you'll notice that largely the performance is similar to how it has been for the last several months. Actually, we have the different assurance levels that we've set. Broadly, we're performing well on the high level qualitative metrics. There are clearly a few areas that we are pressured around and we're working on. And then we have themes around leadership and capability, and as has been picked up, some of the people metrics were the ones we are challenged slightly more, but we have plans that are being drawn together to work on those. And then clearly there's the final domain of finance, which will come into a little bit more detail. So the final part just to draw out then is we still have an overhang of the care notes outage. I will just refer back to the Finance Performance Committee report. We had a very important report which is around waiting lists, which we had quite a long discussion around. And there's a further piece of work we need to do, probably, we think, for around about 3 months, but we need to properly scope it out, which is in terms of properly actioning and closing OPAL referrals that we've recovered onto the record. So that is an important point I draw out for board to note, and that was one of the key points at committee. If that's okay, Chair, I will pause there and sweep up that section before we move on.
So yes, Martin has got a question. Martin.
Robert, I just wondered if you could reflect on whether the rather stringent expenditure controls are hampering or actually not getting in the way of our ability to deliver quality services and delaying any goods and things and resources that we need to deliver our services.
Yeah. So you're referring to the additional controls that we've been instructed to implement by the NHS national and regional teams. No, Martin, I'm personally very content that they are not impacting on, the quality of care. What they are is about putting in place, I guess, across the NHS, uniform, consistent controls that you'd expect to be in place for, organisation systems that are in distress. And we shouldn't forget that as a system we have a planned deficit. I think probably the biggest impact is actually the administrative overhead that goes with it. So all teams are clearly having to look at what they do, and there's an element here of things that we need to have in place and we need to do and we need to follow through. Certainly true that within my finance team this is taking up more time than it would do, but I think the important distinction is this is not changing decisions we would have made around recruiting to roles or so forth. It is very much going through a clear process to make sure that they are defensible and the right decisions to do. So I think it's the overhead that's probably the key issue for me, Martin.
Mark, can I just come in on that to add to that? Because we did have quite a discussion about this, Martin, at the committee, and Denise was explaining how it was all working, and as Robert's explained, it was being well managed, as you'd expect. And I asked her, I said, would I get the same answer if I'd asked all the people responsible for spending decisions that had to wait for their decisions to be escalated? And Denise replied, yes, you would, because we've asked them the same question. So there is a pretty good response from across the trust for how this is going, which is encouraging to hear. Thank you. And Martin, thank you for that question. I think it's something we all probably need to reflect on more and more is money, focus on money, getting in the way, preventing anything to do with the quality of care we deliver. So, I mean, Robert's response was pleasing to hear, but it's something that we do need to keep a focus on. As Robert tells me, every time we meet, money will only ever get tighter and tighter as we move through the years going forward. So we do need to maintain that focus on the quality of our care to our patients, even though the money gets tighter and tighter. So thank you for that, Martin. Robert, you can carry on.
Yeah, I'll move to the finance report, and I guess I'll just preface that with the challenge for the NHS and managers is always about managing quality, performance, and the money. You know, we'd always want more of all of those, wouldn't we? And that challenge remains. So I suppose that's just the contextual piece I put there, Martin. You know, that is where we very much find ourselves. So just turning to the finance report then, and again, I'll draw out some key messages for you. If I may, I'll just draw in a bit of the system context first of all, because clearly that is incredibly important for where we are. So at month 4, our system is off plan for where it needs to be. This was discussed at the ICB, I think just yesterday anyway. So there's papers in the public domain there. But as of month 4, as a system, we were around about £9 million behind the plan that we had. The planned deficit for the system is still the 14 million for the year, and at the moment the forecast is that we will achieve that, but it is fair to say that is becoming an increasingly stressed position, and that probably reflects where we are nationally, and some of the drivers are quite well known around that. Inflation running higher than was expected to be the case, particularly in non-pay areas, and industrial action is clearly exacerbating that. The two bits that feed down from that, and the relevance here is, I'll link it through to our report, is that the things that we are being asked particularly to make sure we focus on by the national team are around delivery of our efficiencies and delivery of the agency targets. So those are things to very much keep in mind. The backdrop of the additional controls, Martin, that you raised is really important, but that just reflects an expectation that consistency is there across NHS organisations. So if I just turn to our report and our performance, you'll see that it's largely unchanged from where we are. We are slightly off plan at month 4 from where we would have planned to be, although I'm pleased to say that the run rate has settled down, and we were showing a marginal improvement between months 3 and 4. I can tell you from the figures that are in for month 5 that actually that marginal improvement continues for month 5, so we get slightly better at month 5, although still a little bit off plan. The key pressures for us are around agency. As of this report, month 4, we're on track against it. Although you recall that what we have is an expectation that some of the additional steps and measures that we put in place will show a continued improvement in the run rate through the year. And I think that's when we look forward where we see the challenge coming in. I can't remember who raised it, but the point around off-framework agency and where we're particularly challenged and where we're particularly focusing, it is on our mental health ward areas and crisis teams where we are working. And this is particularly around where we're having to draw in additional staff over and above planned establishment for closer observation, but also just in terms of the challenge we have around safely staffing the wards and how we plan that through. So there is a lot of work to do there, but there is a very strong response to that. And you'll note that from the report, as of month 4, we had an assurance level of 4 around that. But I suppose I wouldn't be the finance director if I didn't kind of flag that does get tougher as we go through the year. Just on efficiency, the other strand I mentioned, which is really important, we're actually performing well. We still have a few elements of the recurrent efficiency to close out, but that looks reasonably strong from my perspective, and know Sue and the team are working hard through the PMO around that. The one that's a little bit more variable is effectively the non-recurrent additional element we're delivering for the system, and that's contingent on effectively some of those pass-through windfalls that we had. Essentially, if we deliver our financial plan at the end of the year, that part will fall into place. And at the moment, my forecasting up to the regional national team is that we are on plan, albeit not without significant challenges. Just final things to mention, so slightly broader than that. Capital is on plan. We have quite an ambitious programme this year, not only the dormitories, but Redditch and the redevelopment or some of the refurbishment of Section 136 PICU. That is all programmed in, and we are confident we'll be able to deliver that. And then finally, some of the elements around liquidity, and pleased to report we're still very much delivering on the better payment practice code, which is becoming an increasingly important metric for the top team, and is probably one of those metrics that's showing signs of distress across the country as positions drift out and cash financing becomes more difficult. I know there's quite a lot there, so I'm going to pause, Chair, if that's okay.
Absolutely, and we can all look forward to your slide in the AGM this evening, Robert, where you have the ticks all the way down through. I enjoy that one every year on the financial side of the trust. Thank you for that comprehensive report as ever, and I know the F&P committee is across all of this. Does anybody have any questions or any points of clarification at all? Robert stunned us into no, all looking good and pleasing that the run rate is coming back into line, but as ever noting your caveat, which is always there, Robert, that things are only ever going to get more difficult as we approach and go through winter to next year. Okay, thank you very much indeed. They can all be noted, which then takes us through to Martin, audit.
Yes, thank you, Chair. I'll take the paper as read, just pointing out that a very successful closure to the audit on time. External audit is concluded and a clean audit report. I don't take that for granted, but it's very good that we continue that record. I just wanted to draw out one point on the report, because I don't think it comes through in the notes around the sudden unexpected death in childhood report that is currently going through Q&S committee in terms of the detailed actions, but it refers to a shortage in funding associated with our work with that. I just wanted to point out that is a system issue, not one that is specifically within the control of the trust, but is something that we are taking forward as a trust to get additional resource to make sure that we can properly report on the SUDIC requirements and get those back to the level where they need to be, particularly in the light of recent events with the Letby. I should think it will come under a bit more focus, and it's an area that we have to really be on top of.
Thank you. Any questions at all for Martin? No, can I add my thanks to Robert and the finance team for the outcome of the audit. I know we had new auditors this year, so it wasn't just about getting the audit right. It was actually coming to terms with forming new relationships with the auditors. And I was at the audit committee and heard, the comments from the auditors, which were very pleasing to see that they had a great relationship with us. And it's not always the case in all organisations. So thank you to you, Robert, and the team that led that. I know it places an additional burden at the same time as we have the additional burdens from the NHS in terms of spend. So thank you for that. Okay, which then takes us, Jamie, your final report in Mental Health Collab.
Thank you very much, Mark. Starting with the assurance levels, we gave 5 for performance, 3 for finance, and 2 for quality, which is no change from the previous meeting. The thing I wanted to draw attention to most from the meeting was the very useful discussion we had about the future strategy for the collaborative. There'd been some concern about the timescales and deadlines for the transfer of functions, which was made more difficult, partly because of capacity within the system, but also partly because of uncertainty about any implications for this from the CQC inspection. And a general feeling that we ought to perhaps put the detailed timelines to one side and think more constructively about how we could use the existing arrangements to make more progress along the lines that the executive has already been doing the last year or so, so that when we do have greater clarity about the CQC and other matters, we're then able to set a more realistic timescale for the completion of that transfer. In the meantime, there's going to be some consultation underway with partners about how we're going to use the existing arrangements to make more progress and how VCS and local authorities can contribute to that. And also we're going to look more rapidly at how we can bring learning disabilities and autism under the umbrella of the collaborative. So we'll be looking at that, or the committee will be looking at that next time. Only other thing I'd say on this, Mark, is we had a very useful presentation from Worcestershire PCN on district collaboratives, which is probably relevant for much more of the trust than just the mental health collaborative, but a very impressive range of activity that's taking place with PCNs, local authorities and other partners at a local level. Very strong commitment to supporting the mental health agenda, and a great deal of preventative work taking place there, and we're hoping to see more of that moving forward. So that's, if any of you get the chance to get involved with the district collaboratives and their work, I'd encourage people to do that. It's quite impressive. And there are similar arrangements in place in Herefordshire, although they look slightly different because there isn't the same local government structure. And we're due to be hearing about those at the November meeting. So I'll leave it there and happy to take any questions.
Thank you. Doesn't look like there's any questions. So thank you, Jamie. This could be so different is how I describe it. But we have what I would describe an emerging success with regard to the work of the Mental Health Collaborative Committee, and in no small part your steerage and leadership there, Jamie, and your previous experience in terms of partnership working from your local government days has been brought to bear. And one of the key things, as you and I discussed the other day, the most difficult thing is all partners give every impression, and I believe they're all bought into what we in the system are trying to do, and that is never an easy thing to do. And I think a lot of it has been down to how you've conducted that committee. So thank you very much for what you've done there, and I'm sure it goes strength to strength when your successor is announced, and we can move on. Thank you. Which back to you again, Jamie, very briefly, I suspect, on the Charitable Funds Committee.
Indeed, and thank you for those comments, Mark. The main thing I wanted to do, the initial thing I wanted to draw attention to on this is for people to know the versatility of this committee. We spent some time talking about the state of the Chinese economy and its importance for investment, and then we spent some time talking about buying chairs for the staff room at Orchard View. It's a great place to be, the Charitable Funds Committee. More significantly, there wasn't a great deal to report on the investment side, but we did follow Bruin Dolphin's advice on updating our investment policy. We did have an update on the Malvern Legacy project. There weren't any specific proposals coming to the committee for funding, but there's a pipeline underway there, and so at the next meeting, we're expecting to see more concrete proposals for Malvern coming forward. Nothing else to add to that. Can't hear you, Mark.
Thanks, Jamie. I did notice on my phone just ping up a moment ago, the Bank of England decided not to raise interest rates, and obviously that will be a key importance to the investment funds within the Charitable Funds Committee there, or the Chinese
I think the Charitable
economy.
Funds Committee probably knew that anyway, Mark.
Yeah, ahead of the game. You're probably right. Okay, thank you, Jamie. We can note that. The Remuneration Committee report, I don't propose to say anything except what is set out there. Does anybody have any questions about any of that at all? It's relatively standard stuff. Okay, thank you. If we can move past that to Tessa, the Mental Health Legislation Committee.
Thank you, Mark. Nothing out of the ordinary to report from Mental Health Legislation Committee. Would just like to note that we continue to have really good attendance from the associate hospital managers and engagement from them on the agenda. And the next meeting is November, I think, if memory serves me correctly, but nothing untoward being reported there.
Thank you, Tessa. Any questions? No, we can note that then, which then moves us on to a quick operational update from Matthew for items that haven't been so far covered in our discussions or agenda. Matthew.
Yeah, just very quickly. And bear in mind, it's an operational update, and I wrote this nearly a month ago. So, yes, exactly. Okay. So, this week we've got overlapping consultant, junior doctor and radiographer strikes. Obviously, the first two impact us. We continue to take an intelligence-led approach, seeking people's intentions before the strike day. And we've had some more unconfirmed on the day than we'd anticipated. But overall, we've only lost 11% of our consultant workforce to industrial action. Biggest impact directly in paediatrics. But that was anticipated. We've rebooked activity, and there have been no service continuity problems. Good news, not otherwise picked up, I suppose. ICB have supported bids for additional staffing, assistance and delivery this winter in our care coordination hub. So supported bids for a new paramedic post for our single point of access, and palliative care triage nurses are both likely to be supported. Mental health crisis service, we welcome the extension of our CAMHS crisis services to an extended service 7 days a week. So 7 days a week across Herefordshire and Worcestershire, running to 8 o'clock at night. And also the extension of accessible services to deaf and voice impaired people for our 24/7 crisis line as well. We're working through NHS 111, and we're now able to access the text-to-speech, speech-to-text translation service. An update as well to last board's updates I gave on identifying vulnerable services. The ICB and our head of business development are working together, and our head of business development has developed a template that all SDUs are now working through and will be submitted to the ICB, and we'll work with the ICB. Our aim is for this work to inform the planning cycle for 2024-25. Just something in addition on care notes recovery, Robert's picked that up elsewhere. Just to note that it's causing ongoing challenges in accurate performance reporting as well. The large number of duplicate episodes on care notes means that, where referral to treatment times have started, in reality for a person, if they've got a duplicate record, it hasn't, of course, started in the duplicate record. And that's pulling performance down in a number of areas. Task and finish group has been set up to address these. As we've started to investigate the issue, this is in the reports, this is a kind of live update. We've discovered a small number of patients in children and family services with missing clinical record entries. So we have the clinical record entry, but it has not been restored to care notes. That will also be picked up in the task and finish group. And additionally, a very small number of children who were not processed onto waiting lists. Those have all been resolved now, but they had been missed through restoration. They hadn't come through our waiting list triage management system. We've also identified one adult in mental health services with the same challenge. We think that's probably the extent of it. That risk is being quantified now and will be added to the risk register with an action plan coming from the Task and Finish group in the next few weeks.
Okay, thank you, Matthew. Any questions at all for any of that? Tessa?
Matthew, can you just give us some assurance that those patients, the small number that you described who'd not progressed onto the waiting list that should have all now been triaged, assessed, and are being managed safely?
Yep, they've all been triaged, and they've been contacted, and appointments booked into the system in accordance with their triage status.
Thank you. Good to hear. Jamie.
Yes, thank you, Matthew. I was going to ask about your reference to the mental health crisis response and what we've done to improve access to that, including through NHS 111. I seem to remember picking up somewhere that is the intention nationally in due course for all crisis response to be through 111? In other words, no longer supporting local helplines, or have I got that wrong?
No, you're right. So the aspiration is that by April 2024, that kind of option 2 through NHS 111, you fill up NHS 111. If you have a mental health problem, you'll press a particular button, you'll go down a triage route, and one of the outputs of that triage route will be to connect you to local mental health support. We will be piloting that in Herefordshire and Worcestershire from December, and we had clarification this week about whether other access routes were going to continue to be valid. NHSE have started to form the position that there's no reason that you should not continue to advertise free phone numbers. So the national push is on 111. So whatever type of health problem you've got, please phone 111. It'd be triaged, including mental health. But they're not minded at the moment to impose a restriction, because they've had feedback from organisations like the Samaritans, who of course welcome direct contact, and we would welcome direct contact as well.
It seems to me a potentially very retrograde step, and in offering both, that's just isn't that going to be adding to confusion? I mean, we've got local helplines that have been quite successful, and if we weren't to continue those, I'd have thought that would be quite a reduction in accessibility and service if everyone's being forced through 111. And if 111 is an option along with many others, then it's going to be potentially confusing. It seems to me not a good way forward nationally.
I think Sarah offered a comment, and I can actually offer a comment. I was on a meeting at the beginning of the week with regard to this, and it came out as part of the papers I sent out. Jamie, you may have picked it up from the regional meeting. Sarah.
Yeah, I think it's linked, Jamie, to carefully monitoring the capacity impact. Because if you think that we have 27,000 calls to our urgent care helpline a year, 111 is trying to route people who might not know that number or that service in the first instance. So it's people who might phone 111 having access. I think if you start merging them too soon, you're going to have a real issue around capacity and demand with 111. So I think they're trialling it first with the 2 routes running, but it will route into our line. So there's actually the board need to be quite cited on it, because when it goes live on 111, there'll be much greater awareness of that option, and it may well increase and potentially swamp, if we don't monitor it carefully, our own urgent care lines. So I think capacity for 111 and for us needs to be monitored closely when the change happens.
Thank you. The only other thing I can add, Jamie, is part of that, it was marketed as parity of esteem, in that you ring 111 and can only deal with physical health. And it's a recognition that actually there should be mental health and physical health should have the same status. And that was part of the thinking as was marketed at the meeting I was at. But everything Matthew and Sarah says is right from my understanding, but also there is a general acceptance there needs to be a smooth and transition move towards this for the capacity issues which Sarah just explained there. And we'll see whether it's an improvement or not. Okay, if there's nothing else on the operational report, thank you very much, Matthew, for bringing us up to date with that. Colleagues, that brings us to the end of the formal business, but we just need to go through some admin. Item number 24 is all the reports that have been considered elsewhere, and I'd encourage those that haven't been on those relevant committees to examine those. There's some really good stuff in amongst those reports there if you've not on those subcommittees. 25, I've had no knowledge of any documents for sealing or signature. There's also been no AACs, to the best of my knowledge, with appointment of consultants in that time either, which takes us then through to any items to be included on the board assurance framework, with the same caveat, of course, that we're just about to have a full external examination of our risk management process, which would include that. Anything at all coming forward to anybody's minds? Okay, thank you for that. No any other business that I've been informed of. Which then takes us to the date of the next meeting, which is Thursday, the 16th of November. Can I remind our friends joining us either on YouTube or on this meeting that the AGM kicks off at 5 o'clock this evening, and you'll all be very, very welcome. Board members, can I suggest that we reconvene at 1:15 for our private session? And can I reiterate, thanks to Jamie, his last meeting, your contribution, and I think yours was the last contribution, which I think was very, very fitting. So thank you very much, and we'll have plenty of time to thank you in other elements. Colleagues, I'll see you at 1:15.